తెలియజేసిందా సార్?
ఇప్పుడే సడన్ గా ఎందుకో మరి.
ఓకే.
Dear Facebook Pure Urology viewers, good evening one and all. Today our topic is enucleation of the prostate. As you all know, enucleation of the prostate has recently picked up. Main reason is availability of multiple lasers, availability of marcellators, and technically lot of educational videos have come. Lot of the seniors are involved in training the juniors, and lot of the surgeons in India also started practicing. Not the least, but the thulium fiber laser and thulium lasers have reduced their cost, and everything is coming in less than 50 lakhs. So everybody is trying, apart from the stone, the lasers. These are the reasons why. Previously the discussion was on stress incontinence and steep learning curve. Now a lot of youngsters are learning, and they are clearly defining that apical release early can cause decreased stress incontinence, as well as the enucleation process also analytically, technically they are analyzing, and then everybody is able to do enucleation and marcellating the gland also. Even histopathology also, gland is showing any carcinoma, we can detect. So everywhere the awareness of the enucleation has increased. Keeping this in mind, today a different topic actually. Everybody knows that holmium laser 120 watts or like Benz GLS car like that, or BMW X7 type of cars. These cars cannot be compared to the next level cars, but both can drive safely. 60 watts also can drive safely. Now discussion is not that today 30 watts also, some of the surgeons like Dr. Vamsi, who is the speaker today, are able to do it because of the little mechanical one. In enucleation, definitely whether you do it finger, whether you do with a loop, whether you do with laser, you depend on mechanical. So the discussion and controversy is, if you can do mechanical and occasionally cut, 35 watts also is sufficient or not. 60 watts, is it comparable to holmium laser? Dr. Manas Babu is experienced in 60 watts only, and he will be demonstrating his point of view and his version. So these two speakers I will introduce because both of them already been on Pure Forum before. I will directly introduce both of them. So today talk is thulium fiber laser enucleation of prostate, 30 watts like 60 watts. It is not a debate between these two. Again, two cars, different engine capacity should not be compared, but can be done or not is the aim. Vamsi Krishna and Manas Babu. Dr. Vamsi Krishna is MS MCH Urology, currently working as consultant urologist at Care Hospitals, Banjara Hills, Hyderabad. He then pursued his MCH course in urology from Nair Hospital, Mumbai, and he received surgical training in robotic surgery provided by Intuitive Surgicals. He performed more than 500 thulium laser prostatectomy surgeries and 1500 RIRS with retrieval of renal calculi using holmium laser procedure, apart from some complex laparoscopic and robotic surgeries. He has been operative faculty for various national, zonal and state conferences. Coming to the Dr. Manas, who is consultant with Preeti Hospital at Hyderabad. Both of them are from Hyderabad. He pursued his DNB Urology from Lordis Hospital, Kochi, awarded ASU Academic Fellowship for the year 2017 as he was the topper, winner of Pratiksha Gold Medal for Meritorious PG South Zone Urology Association of India 2017. His area of interest, enucleation of prostate and laparoscopy, expertise in endourology and andrology, more than 10 presentations in national, zonal and state conferences. With this introduction, I will request one of the speaker. I think I don't know how the plan of the speakers has been done. One of the speakers, please start the topic. Thank you. Unmute, Manas.
Sir, shall I start? Yes, sir. Shall I start my presentation, sir?
Yes, please.
Yes. Just a sec. Sir, are my screen
Visible? Yes.
visible? Am I audible?
Yes,
correctly?
yes.
Yes,
Yeah.
sir. Yes, sir. At the outset, my name is Dr.Manas Babu. I'm a consultant urologist at the Preeti Urology Kidney Hospital. Just a sec. And thank you, Dr. Chandramohan sir, for giving this opportunity to present thulium fiber laser enucleation of the prostate with a 60-watt energy. There is no conflicts of interest from my side to be disclosed here today. At the outset, first, there is a fundamentally, these two lasers are different. This should be the first point in our head when the talk is going on between the thulium lasers. Thulium lasers can be broadly classified into thulium YAG laser and the thulium fiber laser. The thulium YAG laser is a continuous laser, whereas the thulium fiber laser is not a continuous laser. This is the first point we should keep in our mind when we're talking about the thulium laser enucleation of the prostate. So thulium fiber laser is actually a diode laser in which its beam has been electronically modified to act as a intermittent laser. And here the thulium doped silica fiber through which the laser energy is passed through this silica fiber about 10 to 30 meters long to get the thulium fiber laser. So what are its properties? Whenever we speak about any type of the laser, we should first know about its properties before using that into the clinical applications. So it has a high water absorption coefficient, about 2 times more than the thulium YAG laser and about 4.5 times that of the holmium YAG laser. This translates into a lower tissue ablation thresholds and a faster enucleation. And another important property of this thulium fiber laser is this pulse profile. As you can see here, this is the upper pulse profile is of the holmium YAG laser and lower one is the TFL laser. And you can see here in the upper one, there is a holmium YAG profile, laser profile is irregular and several energy spikes are there. And there is a rapid decline in the energy. Whereas in TFL, it is almost like a square wave, symmetrical, produce a constant peak power. Because of these two differences between this pulse profile between the holmium YAG laser and the TFL, we see during the enucleation, we see in the holmium YAG, there is a scissoring effect between the gland and the capsule, whereas we don't get that type of scissoring effect when it comes to the thulium fiber laser enucleation of the prostate. In TFL, will be the very constant energy will be produced at the tip of the fiber, so that it will be like cutting through the cheese. Cutting effect will be there in case of TFL. And this is a laser beam profile. This also shows that in holmium YAG, there is a dispersing of the energy at the tip of the laser fiber, whereas TFL has the very concentric and the circular laser energy at the tip, so that it helps to precise cutting effect, whereas in the holmium it causes the explosion effect, so that it helps the proper good enucleation in case of holmium. And also the tissue penetration depth is also very less in the TFL, only about 0.15 mm. It is about 2 times less than the thulium YAG laser and 4 times less than the holmium YAG laser. Because of this effect, it has a very good precise cutting effect, and there is also less collateral damage to the surrounding structures. So when we review the literature of the TUFLEP, mainly, many articles have already proved that in this study by the Dimitri Enicu, they have shown that TUFLEP has a very less learning curve. The surgeon who are doing the TUFLEP for the first time, they can achieve the proficiency in less than 8 to 16 cases itself, in comparison to about 50 to 60 procedures in the HOLEP. And also in this similar study, when they compared the HOLEP, TUFLEP, and the monopolar enucleation rates have been shown to be faster in case of TUFLEP compared to HOLEP and the monopolar enucleation, though they did not reach statistical significance level, but definitely they had some advantage with the TUFLEP. And because of its precise effect and lesser shallow depth of penetration, there is also minimal effect on the erectile function after the enucleation with the TUFLEP. And also, TFL has a less energy consumption when compared to the holmium, and it also environmental friendly. Since TFL is very less noise when compared to the holmium, our OTs will be very noise free and silent when compared to the high power holmium YAG lasers. So what are the instruments which we use commonly during the enucleation? Usually in the TFL, we have mainly the three types of laser fibers: 200 micron fibers, 400 micron fibers, 600. For enucleation, either we can use this for 600 micron fibers or the 400 micron, which is the surgeon's preference, whichever you can use. The new addition to this TFL armamentarium is now we are also getting the 150 micron fiber, which can be used for RARS. And coming to the instruments, which we commonly used is this 26 French Wolf made continuous flow working element. This is a laser carrier with a detachable laser fiber, laser carrier here. This is a passive type of working element.
Starch made, na? Starch.
Yeah, starch made. We can use with the regular our 26 French normal to your working element. Outer sheath and inner sheath will be same. Only the working element we have to change for this. Here we pass the laser fiber through this one and fix it. There is also one more working element. This is a one more Indian made. This type we can also find in the Wolf also. Here there will be no front and back movement of the laser fiber. That will be fixed. Laser fiber will be fixed here. Just we have placed the laser fiber, we can do this type of working elements can be used even for enucleation or also for the bladder tumor en bloc resection, and also for the bladder stones can be used with this type of working element. And now newer hot topic of the industry is that slim and the ultra slim. Since we have been working with the 26 French working element, Dr. Philippe from the Brazil has popularized this slim and ultra slim working elements. Mainly the slim is 22 French and ultra slim is 18.5 French working element. Though not freely available in India, but some people are using it, and results have also been very good, but we haven't used it. And coming to settings, usually in the TFL, we have these two type of settings. Mainly one is two pedals, mainly for the incision, and one more is for the hemostasis. Commonly, we use the energy settings of about 1.5 joules and the 33 hertz of energy. When we are working near the sphincter or near the veru, we usually reduce this laser energy to 1 joules 30 hertz or 1 joules 40 hertz also. When coming to hemostasis, commonly we use 0.025 joules and 240 hertz with maximum power of 6 watts. But sometimes when the larger vessels are there, we go up to 0.1 joules and the 300 hertz. That is about to 30 watts energy also can be used. Now I want to show you the real life case of a tuflep here. This is a 80 grams prostate. The patient came with the acute retention. The patient has multiple vesicle calculi. All the small vesicle calculi have been fished out, and the large stone has been effectively treated with the laser, TFL laser, fragmentation and evacuated like this. And you can see here, this is a large bilobar obstructive gland, and all the enucleation is started with the inverted U-shaped incision in front of the veru like this. Here the energy used is 1 joules 40 hertz actually. And then after the incision, placing the beak of the scope at the left paracollicular area, gentle lateral mechanical dissection is done here like this. And by doing this, with this simple dissection, we can delineate the enucleation plane actually. Once you delineate this enucleation plane, you can use this laser energy, as you are seeing here, to increase this field of dissection. As you can see here, doing the no-touch technique. Doing this no-touch technique, there will be less amount of carbonization, and also there is a good first pass hemostasis, and the plane will be easily opened up. Now the plane has been dissected up to the 3 o'clock region. From 5 o'clock, the plane has been gone up to the 3 o'clock position. Now you can similarly, after doing that, again on right side, here the mechanical dissection is avoided. Then instead giving the curtain raising incision at the proximal limit of the external sphincter. After giving this, going into the correct plane, of the enucleation, we are progressing the enucleation similarly from 7 o'clock to 9 o'clock position. You can observe here, there is a good first pass hemostasis when you're in correct plane, and also planes opens up easily as you have seen in the whole leg. Now the dissection has been, posterior dissection is almost completed from about 9 o'clock to 3 o'clock position. As and when we see the bleeders, you can just coagulate as and when they are noticed so that good vision will be maintained. Always try to maintain the no touch technique. As you can see here, gland is been completely, posterior dissection is been completed from 3 o'clock to 9 o'clock position. Then continuing the dissection upwards, gradual ascending technique from 3 o'clock going up to the 2 o'clock position. As you can see here, going up to the 2 o'clock position. Gradually coagulating all the bleeding vessels as and when noticed. Similarly, doing on the left side, after doing on the similarly on the right side also, as you can see here, this is one of the important landmark during the enucleation. You can see here, there is a mucosal strip at 11 to 2 o'clock position. This is the final attachments of the apical tissue from the sphincteric mucosa or sphincter. This mucosal strip is actively incised with the laser energy like this. And the care should be taken to go more posteriorly than going more horizontally, then going into the upwards, so that will not go into crossing the commissure. As you can see here, complete apical tissue has been enucleated, has been liberated from the sphincter and the well-maintained sphincteric mucosa. Once this has been done, after the apical release has been done, now our work is easy. Our main aim is just to go around the curves of, follow the curves of the adenoma. Either it has multiple lobes or no lobes also, just follow the curves of the adenoma. Continuing this section all around, don't dig at one place, just continuing all around the adenoma, maintaining the symmetrical dissection all around. Once we have been completed all around, then we proceed towards the 12 o'clock region. Now the dissection is going at the 6 o'clock, then going up to 7, 9 o'clock position and 11 o'clock position. Now we're coming to the 12 o'clock position. Once the dissection is being continued and going towards the bladder neck, then we see there is a definite change in the caps fibers of the bladder neck. You can see the perpendicular fibers. These indicate that we are near to the bladder. When we incise to these fibers, we reach the bladder. Bladder has been reached, we have to do peel off walls and coagulating on the blood vessels as and when they are noticed. The dissection is continued from anteroposteriorly on either sides of the gland. As you can see here, just always staying close to the capsular fibers. The dissection is coming down up to the 4 o'clock position at the bladder neck. Then the base of the adenoma is reduced, lessened on either side from the adenoma at the bladder neck at 6 o'clock position. Then the enucleated adenoma is just pushed into the bladder, so that by doing like this, the gland is flipped into the bladder with its attachment just at the bladder neck at 6 o'clock position. And these are the final attachments that have been being released effectively. Don't do much mechanical energy dissection here, otherwise there will be bleeders will be noticed. Then a round of pointed coagulation is done whenever there is the bleeders are there. And also we can do vaporization of the residual tissues at the bladder neck like this. All around pointed coagulation is done to maintain the good hemostasis. Good hemostasis is always necessary to do the proper morcellation. As you can see the capsular fibers all around. This is the ureteric orifices. Both ureteric orifices are safe, they are not injured, and the gland is freely mobile en bloc gland is freely mobile in the bladder. This is the final fossa and the well-maintained sphincteric mucosa. Then, since the vision is good, oscillation has been started. Oscillating type oscillation from the from the Karl-Stoss made is used and completed the procedure. Similarly, this is another case with a large gland, about 130 grams prostate.
Manas, Manas,
Yes, sir.
we will take a break here and we will see the 30 watts and then come back to you.
Yes, last slide, sir. It's done. Last slide.
Okay.
I will finish it off. 2 minutes. 2 minutes. And this is a large 130 grams prostate with a trilobe or large median lobe. And similarly, en bloc enucleation can be done. A similar technique with early apical release. This is the post-enucleation fossa. You can see well-maintained capsular sphincteric mucosa is well-maintained. You can see all around the capsular fibers and the widely opened fossa. And inside you can see this en bloc tissue with both lobes, and the intact median lobe also can be seen here. Intact median lobe also seen here. This is our experience of about en bloc enucleation with about 50 cases. Our enucleation time was around 83 minutes. Average enucleation time was about 83 minutes. And we had a enucleation rate efficiency of about 0.7 grams per minute. And average catheterization time of about 2.46 days. And we had a stress urinary incontinence at the 1 month of about 10%, whereas at the 3 months, we had about 2% of stress urinary incontinence. And amounting to a total complication rates of about 18%, whereas in others, prevalent literature has shown it about around 21%, 20%, and about 17%. To conclude, as Professor Herman in this editorial has stated that enucleation is enucleation is enucleation. It is not the equipment that is responsible for the efficacy of the endoscopic enucleation of prostate, but the enucleation technique whereby the complete removal of obstructing adenoma is should be achieved. Thank you.
Okay. Now we have seen with 60 watts. Now let us see, can we do with the same thing with 30 watts, 35 watts? Dr. Vamsi, who is doing for last, in fact, he is conducting live workshop also. So let us listen from Dr. Vamsi, and then at the end we will have discussion. Over to you, Vamsi, please.
So, good evening, Chandramohan sir, and all the pure urology viewers, Manas. First of all, I thank Dr. Chandramohan sir for giving me this opportunity to share my experience in thulium fiber laser enucleation of prostate. So, I'll start my presentation. So, is my screen visible, sir?
Yes, yes.
So as rightly said by Dr. Manas, enucleation can be done by any method when you have the right technique and plane. So the same analogy, that's why I started earlier. Before starting the use of thulium fiber laser, I had a thulium YAG laser machine, 150 watt. So with that, I was using doing vaporesection, then vapor enucleation, and then anatomical enucleation. So there was a significant learning curve in the beginning, which was cut shorted by the vaporesection technique. So I'll tell. So what are the modes available? I differ with Manas in the different modes available in this machine. So there is a continuous wave mode also available in this thulium fiber laser machine. So I use a 35 watt. Initially, I thought of using it only for stones. Then when I experimented with the prostate, then I found the efficiency to be similar or even better as compared to my 120 watt for enucleation. Compared to vaporesection or vaporization, it is not better compared to the YAG machine, but for enucleation, it is slightly even better. So
Vamsi,
why? Because yes, sir.
you have used extensively thulium YAG laser.
Yes, sir. For
You
10,
have
8
used Homium also?
sir.
You have used Homium also?
I have used Holmium every now and then because I had the opportunity of having a 100-watt Holmium in my hospital where I was working. That was I was using whenever the machine was for maintenance or something. So Holmium also I did around 8 to 10 cases enucleation.
So in thulium YAG laser,
Yes, sir.
what are the, I mean, just as a, because I don't have experience, I'm asking before we go
Yes,
into introduction.
yes, sir.
Thulium YAG laser comes under 100, 200, 250 like that. What
Yes,
is,
sir.
why it is so high wattage is there in thulium laser YAG?
Yeah, thulium YAG laser basically the how we do prostate is basically dependent on the vaporization efficiency of the machine, vapor enucleation or vapor resection.
Okay.
Unlike the holmium, as you said, it is scissoring effect is not seen. Tissue tends to get stuck to the capsule. So in the beginning, when I was learning, I was using mostly vapor resection technique, that is removing the gland in bits and pieces.
Okay.
So, this just for the idea of what is vaporization, you can view the slide, sir. This is what I was doing in the beginning of learning curve. I was trying to enucleate, but every now and then I perforate, every now and then I enter a venous sinus, and then I thought I should be
This is with
slower.
thulium YAG laser you are telling.
Yes, yeah, laser.
There you
So
never used to apply mechanical pressure or directly used to cut.
yeah, in the beginning, when I was not acquainted with the plane and the shape of the gland, I was using cutting the probably first few 40, 50 cases. Then in that direct cutting, it's difficult to visualize where the capsule sometimes. So then I shifted to vapor resection and removing larger chunks. And at the final, removing the smaller bits which are just left over or bumps.
That
So,
produces lot of coagulation effect and charring. You agree?
but I agree. But I've been doing, as you mentioned, last so many cases. I never found charring to be of any significance in terms of
Post
dysuria. In
operation.
terms, so it only is a visual
Feeling.
feeling that it leads to some problems. I have been following all my patients. So those patients who came with bladder neck contractures, very few ones, were actually when there is a significant infection, prostatic abscess, or I had to remove the whole gland because of infection, even if it's a small gland. All these things, the general rules where small gland don't remove only incised. When we have to bypass because of various reasons, then these people come with bladder neck contracture. No patient with charring or anything later turned out to be a large gland or medium sized gland came with bladder neck contracture or immediate irritative symptoms in the post-op. So
What
whatever.
was the change? What was the change you made? Because quite a long time you are a known surgeon for thulium YAG laser also.
Uh, Actually, when I viewed your thulium fiber laser dusting of the stone, I was very impressed and I thought I should shift from holmium laser RARS to the thulium fiber laser RARS.
Yeah.
So I got the machine 35 watt because I was happy with my thulium YAG laser. Then I thought why not try a prostate also with this. It's a
Yeah.
surprise. I did not plan it to buy for the prostate. I
Yeah.
bought
Yeah.
it for only for my stone. So when I used thulium fiber laser with the specific techniques which I'm going to mention,
Yes.
so I felt what I was doing, just going back to what my phase of from initial vapor enucleation to vapor resection. Then again, I was using combination of a bit of blunt and then finding the plane and vapor cut. Blunt push vapor cut, blunt push vapor cut. So I'll show a video also. So in this combination, I was doing a vapor enucleation with a YAG laser. So I was etching a cavity with a combination of blunt and vapor cut because pure vapor energy laser, you will not see the plane because the tissue gets stuck to the capsule. That's where there is a bit of backseat it takes compared to holmium because holmium would enters the plane and then it will lifts the gland off the capsule because of the blast effect. So here there is no blast effect; it just vaporizes the tissue. So you will see both sides as a bit of yellowish color sometimes. You won't make out the capsule unless you bluntly push the gland or sometime or lift
Yes.
it.
This is the problem
So
we are facing.
yeah, so this when I got the machine Thulium fiber laser, initially I was what I was using with YAG laser, I was using a 60-watt setting for enucleation. And whenever I want to vapor resect, like there is a large malignant prostate, there is no plane or something, so I use vapor resection for removing the malignant prostate gland, channel TRP, channel laser TRP. I use a higher setting, like I will go to 120 watt or 130 watt. So for simple enucleation, 120 watt is actually difficult to do because you might tend to perforate. It's like riding like your Mercedes car in a very narrow road. You might injure. So to enucleate, I was using 60 watt of YAG laser machine. So when I got this 35-watt machine, the highest energy or power I was able to achieve with continuous wave mode is 30 watt, not 35 watt. So I was telling 30-watt thulium, 30-watt thulium. So 30-watt enucleation, my experience is as faster and as effective as 60-watt YAG laser machine. So my job was simple. I was shifting from 60-watt YAG is similar to 30-watt fiber laser. So the physics behind was explained by Manas very clearly. There is a the efficiency of the pulse of the laser is completely achieved. The square shaped delivery of the pulse wave is, all these factors make the 30-watt as effective as a 60-watt YAG. This is the key point to note. So when you are enucleating with 60 watt, it is easier to shift a fiber laser 30 watt. That is for a thulium person like me. And for enucleating like a holmium laser, like what you are using, pulse wave, I find the blast effect is equally good, not so good as holmium, but at least you will make out the difference between gland and capsule compared to holmium. Initially, I feel whenever I was in the beginning of my holmium enucleation, gland and capsule both appear to be white, and there is some fluffy tissue, very difficult to identify capsule in the beginning. Later when we got experienced in doing enucleation, when we reach the plane, how the holmium lifts the tissue of the capsule. Similarly, I found pulse wave mode of the thulium fiber laser has similar features as holmium, unlike the continuous wave mode of fiber laser itself or YAG laser. So if you want to do a anatomical enucleation, it is better to put in pulse wave mode. If you
That
want
pulse
to do
wave
a,
mode in the company is giving that pulse wave mode button separately.
yes
Manas?
sir, what you are doing, you have a setting. This is a
So,
pulse mode.
so
So
what we are using is a pulse mode setting, sir.
yeah, what you are using is a pulse mode. What the company recommends is a pulse mode for prostate actually. So I experimented with the modes, and then I found there is a continuous wave. Then I started using vapoenucleation. Then I found it is good. So if coming to
So
pulse mode
ultimately,
also,
you are recommending pulse mode only.
yes, I recommend pulse mode if there is a
That
good
is
plane.
what we are doing, Manas.
Yes, sir. We are doing the same pulse mode setting, sir.
So for
Now,
both of you will recommend that pulse mode is the mode which we have to do. Where it is written in the beginning only it will be written.
In the
The sub-
setting, sir, in the setting in this
Ah,
IPG machine,
ah,
there is a setting called incision.
ah.
In the incision, the same energy as Manas uses for his 60-watt machine, 1.5 joule,
Yeah.
and instead of 33, here we can reach only 23 hertz, that is
Yes.
35 watt.
Okay. Okay.
So with this same 35 watt, even a large prostate can be removed.
Yeah.
So
sir,
because once we reach the plane, we all know, there is no much use of the energy. Well, the anatomical enucleation doesn't need energy. But vapoenucleation, what I was suggesting with the continuous wave, if we have a better energy like a larger machine, a higher wattage machine, or this thing, your result will be faster.
sir,
But if you are in the good plane again, when you are pushing the gland and finding the plane and again cutting, push and cut, then also if you are in a right plane, you don't need a higher energy than 30 watt in fiber laser or 60 watt in YAG laser.
Yeah, this is the point which is very important, that you are saying that a little bit of the curvature and the volume effect of the gland you utilize, a little bit push and then cut. For that
Yes, sir.
cutting, you don't require a 60 watts is your main point.
Exactly, sir.
Main point. Do
Yes,
but Homeom
sir.
persons will never do any rotation or mechanical force. They never push even 1 mm. Is it correct, or they will also push?
They don't need to push, sir. Holmium automatically lifts the gland,
But
and
in the future that we have to acquaint, is it not possible with thulium because of its property, absorption high coefficient? It
no,
won't.
sir. I don't think. Yeah,
In the
even in
future,
pulse mode, I don't suggest we need to push. We can just be in the plane, have a continuous pressure being in the groove. Automatically, the tissue lifts. We don't need to push bluntly. That's what my
do you
experience
agree,
is.
Manas, with this?
Yes, sir. Yes, sir. Because only thing, basically, it is a anatomical enucleation. Just we have to be in first. You have to identify the correct plane. Then just follow the curves. That's all. For following the curves and separating
You
the
need not push. That's what Vamsi is saying.
yes, sir. You need
Chalo.
not push. Only thing is when there is inflammation, there is sticky type of adhesions are there. Then only we need energy source to cut. So
Okay.
that even we can do with the monopolar also bipolar also same thing. And one more thing, sir.
Vamsi, if
Sir,
you don't want to get that blackening or charring, some people are recommending, like seniors which I have interviewed in Pure, if you keep a 1, 2, 3 millimeters away from the tissue, that charring also will not be there. Now Manas is trying to implement that. What is
but
your
your will be very slower, sir. If you in
yeah,
unlike holmium
yes,
it's a blast effect. You should be
yes,
keeping one
yes,
mm back.
yes, yes.
Thulium, I feel you have to contact with pulse mode with this setting. Manas, you try
Yeah,
with this setting once, okay,
Yes,
and try to touch the
continuous.
gland, touch the
Yes,
tissue. You will
correct.
you will not get charring. There is no charring, and it is actually even clearer because the capsule is white, gland is yellowish,
Yes.
hardly any charring, and you will get a good plane. You continue to touch the gland and cut it. You don't need to push in between at all in when you
Very
are
good.
using a pulse
That
mode.
is a very valid point today, that 1.5 joules and 23 Hz is low wattage. Ultimately, Manas was telling that as the mission gets older, we have little older mission in BHL. He is saying that I am very comfortable with that mission because it is lifting. Probably its energy efficiency is less. Now, what you are mentioning is 1.5 joules, 23 Hz, total together 35 watts. Does good job with cutting by touch also with pulse
Touch.
mode, and you
Yes, sir.
will not get that much charring is your, because you are
Yes,
experienced, you will consider that.
yes, sir.
Okay, right, please proceed.
So the same thing, sir. When you want to incise the gland or anatomical enucleation and even bladder tumor also, because between the plane between the mucosa and the muscle, very good plane. You can don't need a vaporization. You just have to lift it and cut it. So these techniques you can use the pulse wave mode of the machine in continuous if you want to start. So for the beginners, it's very easy to watch a good en bloc resection done by a senior nucleation person, Dr. Manas. But in the beginning, in the starting at the apex, it is easy to release, but somewhere in the middle, we might lose our way. So I would suggest before doing an en bloc resection or even enucleation, go for resections first. That's what my experience. I don't know other people how they started. So for
What is the difference
resection,
between vapoenucleation and incision, Vamsi? Enucleation, vapoenucleation and incision. Actually,
uh,
incision is only the capsule incision, that means.
in the if you want to just do a bladder neck
Yeah, night.
incision,
Acha, acha.
uh, or 5 o'clock incision, 7 o'clock, or only incisions, it is
Yes.
pulse
No,
wave
no, no.
mode is
I
better.
was also about to ask anatomical enucleation versus vapoenucleation. Anatomical enucleation is where mechanical pressure is used.
Yeah,
To,
my terminology here is anatomical enucleation is you don't need to exert energy more energy. It's only you're being in the right plane that the energy will just lift the tissue. And here in vapoenucleation, we have to lift the tissue a bit, find your stay in the capsule, then cut.
for that, continuous wave mode is used. Huh?
Continuous wave mode is faster, sir. We have to lift the gland, see you are in the right plane, then cut. Lift the gland, see you are in the right plane, cut.
I am doing
So
like that. I am doing like that, to be honest. Manas, what do you agree?
sir. Actually, I bit I don't this. Sir, actually, main basic difference is between anatomical endoscopic enucleation and vapor enucleation is in vapor enucleation, as sir said, we continue the bit by bit. We have to continue keep resecting that this one till we see the pinkish capsule. Usually we see in the thulium sir. But vapor enucleation is not correct and anatomical enucleation. What I feel, sir.
Yeah, I'll show you, sir.
Vapor enucleation is somehow enucleation, whereas anatomical enucleation, every time you are on the capsule.
Yes, sir.
Yes,
That's
sir.
like
Correct. Exactly, sir. Exactly. But you will achieve equally good.
Perfect on the capsule means anatomical enucleation. That is what the aim is, and majority of the homeom people say that they are very good in lifting that because it naturally lifts that plane.
Correct, sir. Exactly. Holmium has advantage of naturally lifting the tissue,
Whereas
whereas
thulium
thulium, you have to use your technique to know where you are and then lift it, sir.
okay.
So this video you might have seen,
Yes,
sir.
yes.
I'll
So,
anyway present.
there need
See,
not sequence
see,
of
this is vapor enucleation, sir. Are you able to see, sir? See, see the right screen. Here, I am pushing a bit.
yeah, I do like this.
Yeah, cut. This is the capsule, this is the gland. Still, I am doing proper anatomical enucleation. I am removing the whole gland. Now I am pushing and cutting.
Yes, I also do like this.
So you don't need to do this when you are using pulse mode. I feel, sir. I don't know, but when I am doing pulse mode, I don't need to push also, sir.
So this pushing, homeom people will say that no, we never
They don't need pushing at all, sir. When laser is fired, the tissue automatically gets separated. In thulium, it won't get separated, sir.
That is the problem.
So you can see one more video where
some areas you miss the bus on either side, whereas anatomical enucleation you don't miss expectedly theoretically.
Yes, sir. Correct.
Okay. Please proceed. Sorry, we are bothering you.
No, sir. These are good relevant questions. This is what is.
Audience are there, nearly 118. So they are all probably enjoying this discussion because they want.
So for these people, use if you are difficulty to enucleate in the beginning, do vapor resection repeatedly. I'm telling it because it's not so easy to achieve that plane and then continuously be in the plane. So these are settings I mentioned for continuous wave. This is a setting called fulguration in the machine. So there you will have the continuous wave mode. So the maximum power you can achieve is 30 watt. And most importantly, to achieve the complete delivery, 400 fiber is better, sir. So instead of 600 fiber, when you are using a lower wattage, because the density of energy that is getting emitted will be diluted if you get 600 fiber, and the efficiency will be lesser. So when you want to enucleate with 30 watt or 35 watt, you better use a 400 fiber.
Okay.
So I'm just showing one of the cavity large gland. Just the initial and the final fossa only. This is a vapor enucleation video for using a 30 watt continuous wave mode, 140 gland. This is a large gland. So I'll show the technique in a next video, but just wanted to have the initial idea how efficiently we can achieve even with 30 watt machine also. This is a large gland you have all seen. So I have enucleated. These are directly going to the final fossa here. These are the right orifice very near. In enucleation, the problem is orifices can get injured. Here you can see almost left orifice is almost injured. So you can see there is a capsule in between, somewhere here and there, and some little bit of patch of gland.
Yeah.
That see this is a capsule all around and little bit of patches of gland here and there.
Cavity.
But the cavity is good. There is a good hemostasis. I thought it was a venous sinus, but it was not bleeding. It might be a small crevice also. So this cavity is almost similar or same as anatomical enucleation.
Yeah.
So these are large lobes, each around 60 grams, maybe 3 lobes were there. I did a 3-lobe technique. So this is what you can achieve even with this machine.
For incision, which is the best setting, Vamsi?
Same pulse wave mode, sir. Pulse wave mode.
Pulse wave mode.
Yeah, 1.5 and
25, 23.
23.
Okay.
With this machine, I got that highest value. But if I got a 60
I
watt,
will try with
uh,
high frequency because I have 60 watts. I will go with 1.5 and 35 watt Manas said because I have that luxury.
yeah,
I will.
Even you can use one joules and 60 hertz also, sir. That will give even more better cutting also.
What happens if frequency increases? Both of you a comment. What happens if energy is decreased and frequency? Like in energy is decreased and frequency increased, popcorn effect in huge pop.
like if you want to separate that blast effect, which you want to compare with holmium, is better with a higher energy, sir.
Okay.
So 1 joule, I tried with 1 joule enucleation
What
also.
causes more charring?
Charring,
More energy, more joules are increased, more charring will increase.
you have to be faster. If you are slowly doing it, you will get more charring.
So you should
Even
book
if I was using 120 watt, if I
laser
using,
fiber, very fast in the plane so that it looks beautiful. What I observed. If by chance if the laser fiber stuck in the gland, it becomes total black or
yes,
brown. Isn't it?
yeah, you should be in good plane, move faster, then charring won't be there. But we have to get out of charring, sir. Charring is not of any significance. Only the holmium guys will point out thulium charge, nothing of any significance. So
Okay.
if it is charring and people are complaining with all the problems, I would have left the procedure by now. But I'm quite happy and
Yes.
progressing.
That is also correct. Okay.
So this is the one more video of the continuous wave is a 180 gram gland. So I recently started N block technique. So before that I was using 2 lobe 3 lobe technique. So if there is a good median lobe, I'll do a 3 lobe. If it is not there, I'll do a 2 lobe. So because it is a 30 watt continuous wave, so it cuts definitely faster than even the pulse wave mode. Even the initial incision is faster. So you can see the 5 o'clock incision being taken. This yeah, you can say there is a charring is there, but as we have just concluded, charring is of not of any significance. So this is a 7 o'clock incision being taken. Once you see the leash of blood vessels with a white capsule on it, even with this thulium, you can see the white leash of vessels with the white capsule. Then you can stop taking incision. That's where you stop. Join both the planes. One important tip: I reverse the scope by 180 degrees. That will automatically push the gland away from the capsule. So in this video, you can, as in the earlier video, you can see capsule and a bit of gland. Where I bluntly push, you will see capsule. Where I cut, there will be a little bit of gland. So that's how vapoenucleation happens. I'm just fast forwarding is a large video, so I'm forwarding it. It's a oozy gland, large gland. So this is a cavity I was able to achieve. This is near the apex, the tissue. So pulse mode.
Oscillator you use?
I use a Wolf Piranha modulator, sir.
Wolf.
And I use a Wolf 24 resectoscope, as we already mentioned, saw the slim hole up and all. I've been using only 24 resectoscope and very few stricture rates, very less. Those who had a stricture were already having some submeatal narrowing or even a tight bulbar urethra. Then I used to do
24
Otis
which
or
company you are using? Which company? 24?
Wolf, sir. 24 outer and 22 inner.
Uh,
Whenever it is,
laser working element is there for that?
yes, sir. Laser working element is also there. If somebody is using Wolf monopolar set, we just have to buy the laser working element. Uh,
I have monopolar 24/22.
then you just have to buy the laser working
Yes,
element of
yes, sir.
wolf.
We have ordered for
That
that, sir.
will be enough. Yeah, that should be enough, sir.
Someone told, you ordered for that?
Yes, sir. It's there. It's on the way.
24/22 wolf is very good.
Yes, yes.
Yes, sir.
And
But you have to buy a morcelloscope from Wolf. Your store's morcelloscope won't enter this
okay, we
thing.
can change with that part only nephroscope. By the time urethra might be dilated a little bit.
Yeah, that you can do, sir.
Because marcelator buying another one is costly.
Yeah,
I
correct.
waited a long time to buy the marcelator.
Yes,
Not
sir.
Piranha is costly, but a lot of people recommend it. But I am enjoying the Starch marcelator very well. It is around 12 lakhs or 14 lakhs in between. I got, I don't remember exact figures, but Piranha is I think 18 lakhs.
Piranha 15. We got Wolf for 15, sir.
15, something like that. 3 4 lakhs is more in Piranha, but Piranha,
Now even Biorad is coming with Piranha. That's also good, sir. It is around 10 they are quoting.
yeah,
So
yeah, that
probably,
is also good. Biorad may change the scenario in the.
yeah.
They are coming with direct suction, but only problem is 1 foot, 2 foot press, 3 foot press like that they kept.
Yeah, so, but once you are used to morcellation, it won't be, initially it will be difficult, sir. Once you are comfortable, you will be able to do it,
Able
sir.
to. Okay, right. Next.
So pulse mode, this actually I took this patient for a bladder neck incision. I used 17 French integrated scope for incisions. So when I took this gland for incision, I also found probably an inverted papilloma at the dome. So I continued with the same 17 French without any laser working element. I used a pulse mode to remove this bladder growth. So this is a 400 fiber. I was pressing the hemostasis button, the other setting.
The air
One
bubbles
joule,
will come in
uh,
pulse mode.
sir.
Air bubbles will come more in pulse mode.
They're more in continuous mode only, sir. More in continuous mode.
Culture.
No, pulse mode, when you use hemostasis button, air bubbles will be more, sir.
Okay, okay. I did not observe that part. So here also like en bloc resection. Once this is a muscle, this is a tumor. So we have a plain gap between the mucosa and muscle. Even 10 6 watt is also enough for bladder tumor. So we
Yeah,
don't
yeah.
need a
Yeah.
say one more reinforcement that 60 watt or 30 watt. 30 watt is enough for bladder tumor.
Yes, 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 yes.
So I'm separating the tumor of the muscle. So this is only I'm using 17. That vision is poor because there is no continuous irrigation. I was intermittently stopping and letting out the bladder. So I didn't want to use a 22 sheath also. Yeah, when I won't be able to enter with even 22 to 24, I use a 22 with intermittent irrigation with a 22 working element, 22 inner sheath only, and complete the job. Unless there is a large gland where I need a continuous irrigation.
This is one of the beautiful application, I must say, dome tumor. So nice,
Yes, sir.
like a designer cut, we can cut.
Yes, sir.
You need not perforate because it's a 0.15 mm depth. Perforation
Exactly,
in
sir.
the bladder is impossible.
Yes, sir. Very difficult.
Perforation is easier than
We
perforate.
can see a good plane muscle all around also. Unlike it's difficult to achieve with loop. We can neatly like just like we have removed a bed sheet of the
Hmm.
mattress.
True. I really agree that.
This is incision with pulse mode, sir. You can, if you carefully observe, there is a blast effect similar to holmium here also.
Hmm.
So unlike continuous wave mode, it gets stuck in pulse mode. The same energy settings.
Compared to your previous video, this video looks less charring.
Yes, less charring. I am touching also.
Uh,
Unlike Manas, where he was keeping it 1 mm, and it is faster. Even at 35, it is
Sir,
equally
you are
fast.
using short pulse or long pulse, sir, here?
There is no setting, Manas. There is only
Sir,
incision.
no,
One.
in incision in most of these TFL machines, there is a short pulse, medium, and long pulse. Most of the time with enucleation, you use the short pulse only. Whereas
Okay.
in hemostasis, you keep it into the long pulse, sir. In this
Okay.
water bubbles, bubbling effect, and everything, usually we see in the long pulse, sir. In
Okay, I
short
will
pulse
find out
also,
with the company person. What
yes,
he gave me setting was the same setting. He did not change it. I will find out whether these
yes.
pulses are.
There
I
is
will try
only
with all the different,
yes, sir.
and I
Only in
will
that
get back to you.
only in that incision mode, we'll get that short, medium, and long pulse options are there. Lower
Okay, okay.
lower corner, you can change it.
Oh, okay, okay. Lower corner.
in cutting mode and the soft tissue cutting, it is not there, Manas.
In soft tissue casting only we'll get that short pulse, medium pulse, and long pulse.
Enucleation you do in CT mode or what mode you do?
What's that? I didn't get you.
Normal enucleation is done in which what mode?
Same thing. So pulse mode only incision. During in enucleation, we'll for enucleation we'll have that incision effect, incision pedal, and then hemostasis pedal. In the incision pedal,
you are saying that short pulse. Oliver Traxler says that by nature, thulium fiber laser is short pulse laser.
yes, sir. But,
Pulse.
what Oliver sir is saying is only during the lithotripsy. In lithotripsy, there is no short pulse, medium. During this soft tissue application, you have the short pulse, medium, and long pulse. Short pulse mainly it helps to you will get little bit of that blast effect which we see in the whole mirror. Whereas in long pulse, there will be mainly the water bubble effect more will be there. It's mainly used for hemostasis.
Okay. Valid point.
I will thank you, Manas. I will try short. I will check whether I am in short pulse. I feel it is a short pulse because
Maybe I think it is in the long pulse, sir, because bubble effects are there. Maybe it is in the long
okay. I will see. Check back and get back to you, Manas.
Yes,
I will
yes,
see.
no
So this you again. I am replaying the same video. You can observe how the this thing is there. The speed. If you touch and cut, it is faster. I have seen your video. You are being 1-2 mm away. I feel you can be faster if you touch also. Nothing will happen.
Yes, yes, sir.
Tissue gets separated very nicely. I am using 17 integrated, not even a working element.
Okay.
With only fiber pressure only, I am achieving the separation.
Yeah, it is faster.
Yes, sir.
Bubbles
So,
are a little bit.
yeah. So these are my results, sir. Actually, I did not update when I was using this presentation was an older presentation 1 year.
Now, any more video I would like to see with 35 watts enucleation video. If you have one more, we like to see.
I will check, sir.
Actually, two videos. In fact, we have this thulium fiber laser versus homium workshop on September 11th to be organized by Manas, and you also will be the faculty, Vamsi.
Thank you, sir.
We will be coming about the faculty list in the next flyer. It is only 1 day workshop, Sunday, so that people can come in the morning and go in the
Leave in the evening. Yeah.
evening. So it is a very user-friendly workshop, and we have kept 1,500 rupees for registration, and
Nominal.
the juniors will get benefited. Maybe two cases, 3 cases homium, 3 cases thulium we wanted to.
Yes, sir. We can also show like one side we can use continuous mode and other side we can use pulse mode.
Yeah. That all can be done.
Yes, sir.
We are trying to mobilize the cases already. 4 cases mobilized. 3 more months time is there. If we can demonstrate 6 cases in the 7 cases in the workshop, very good. It will be useful to those who are aspiring for enucleation.
Sure, sir. So probably it is there in a different hard drive.
No problem. Now let me ask the questions, and both of you can close the screen, and we will have face to face. Number one question to Vamsi.
Sir.
In a large gland, when suspensory ligament is very tight, when you are not able to see the dome of the bladder, do you think that water logistics any problem? Overall in enucleation, when should we on the outflow? When should we off the outflow? Any tips and tricks you wanted to give?
In the large gland, it is as you said, reaching the roof or the toe lock is really we think even the scope will bend or even some injury happens.
Yes.
Directly entering that plane, because when you are reaching that capsule, it's unlike TRP where you go from superficial to deep. You
Yeah.
have to penetrate through the gland and reach the capsule. The angle is much higher. So in that situation, once we better to avoid an en bloc enucleation, go for one lobe enucleation, try to achieve, then you'll have some space. Then
So
remove
answer is go by step, not in one go en bloc. Try in a large gland without experience. That is the answer. One answer.
Yes. Go
And
remove.
surgery.
You will get space also. You will get space also once you remove the gland, and maneuverability is easier. Scope will reach the roof. You can come back to the roof if you have left some tissue and then retrieve it. It gets easier, sir.
During the surgery, any part you purposefully distend the bladder during any part of the enucleation?
As I observed Dr. Pankaj Maheshwari sir, when he was doing, he mentioned he will distend when he is reaching the bladder neck to avoid ureteric orifice injury. But yeah, probably I did not try it, but it might be helpful, sir.
Yeah.
Uh,
Manas, for you one question. When you start in the beginning, any enucleation,
Yes,
first thing you will give the incision in the front of the veru. That time you will be very enthusiastic to cut very nicely, to do very neatly. Suddenly bleeder will come and will spoil our view. And the bleeders at the submucosal levels will irritate even though they are not. And vision spoils and you try to do enucleation of this thing. What are your laser settings so that it is hemostatic as well as cutting when you do in front of the veru? This is where I feel on lucky day it will be very nice and the entire thing goes very well. Some people like Herman and everybody says that first 15 minutes you spend good amount of time, rest of the surgery is easy. What is your take on that?
sir. Even with the most experts in the field, in their videos also, we see that initially 15 minutes during the mucosal incision, definitely there will be bleeding will be there, sir. Because prostatic adenoma is a very vascular gland, basically to say. Definitely there will be bleeding will be there. One small trick what I follow is during this initial time is also because near Veru, I usually reduce my laser energy. So 1 joules and 30 hertz I keep. There will be very minute cutting will be there. Even though as and when we see the bleeders, we can coagulate that one. And also you can use the pump, pressure pump at the initial level, only at the initial only, so that you will get a good vision. As you give the incision, then you have to stop the pump. You should not use the pump continuously.
Okay.
Because definitely there will be bladder injuries will be more with the pump. So only use it in the initial stage only.
Okay.
What I follow those things.
Vamsi, second question for you. When you reach with enucleation in the middle part of the gland, some people recommend that you always come from top to bottom, top to bottom, top to bottom. Never go from horizontal below, that is 9 o'clock to 3 o'clock to 9 o'clock position. You don't go. In pushing and cutting, this is especially vapoenucleation, what you said. If you push a little bit, it will cause more perforation down. So, for which the people advise reverse the camera, and second thing is come top to bottom. In the middle part of large gland, one suggestion you are given is remove the median lobe so that you will get space, so that one lobe will be pushed in the center.
yes.
That I am feeling very easy. Nowadays, I reduced my ego in that enucleation. I used to try in the beginning, even when I am not experienced en bloc, then I suffered. Now, what are your tips and tricks? Once you come to the middle bulk of the gland, last time in the conference you explained nicely the curve,
Yes.
the apple, the whatever orange, the curve is up.
Yes, sir.
You have to come up. What do you think? How will you do that? Tips and tricks.
Once I make the initial 5 and 7 incision or a 6 incision in a in a two lobe technique, I will have an assessment how long the gland is. So then I will have an idea where I am going to at the middle. So if there is a this is a bladder neck and this is a veru, once I come and see where I am at the middle, then I have to be very I have to take the tip of the scope and then lift it much higher than what I need in this part
Okay.
in the beginning. And in this when I reach after the equator, I call this as equator. So
Okay.
once I cross the equator, I tend to cut more towards the gland, a bit more.
A bit more.
I can cut in the center also.
Okay.
So
So you
this
will do
how,
around 2 meters on the gland than the capsule edge.
yes, I will err towards the gland. So I can avoid perforation or subtrigonal perforation or all my perforations I reviewed.
If
Most
you do
of them
like
happen after the equator.
If you do like that, is there any chance of going into a wrong plane? Because this is a cutting type of laser, it immediately cuts. Wherever you,
Whenever I have doubt, I lift and then see the capsule is seen, sir.
yeah. So
When I have doubt, blunt push.
this small lifting of the gland is very
Yes,
useful, I think, in thulium fiber laser enucleation. And you see the white color tissue, then reorganize, and that reorganization is very easy because it simply gets you back into the plane.
correct, sir.
And like people say in homeom, if you miss the plane, it is difficult to come back to the plane.
Yeah,
Whereas with your technique of vapoenucleation or vaporization, you can come back to the plane again in whichever level you missed.
Yes, because it's efficient cutter. Even if you miss a plane, you can just join it and remove it through the gland. Also, it cuts. Many times, inflammation is there. We might when I try to lift, I lift along with the capsule and we
But
perforate.
as a
So
matter of fact, this laser is highly coagulative incision. Highly
yes,
coagulative incision. So for a beginner, you never worry about bleeding in this laser.
correct.
I don't know coagulation. If somebody comments that it is less, I'm surprised. You when you cut the infundibulum, I have seen huge bladder vessels just burning like monopolar artery.
Correct, sir. Correct.
Huge bladder vessels at the base, they just burn. It is luxury. Even if you burn completely with coagulation mode and then take a monopolar resection, still you will do less better job. For that purpose, also you can use. I think.
Yes, sir. I
Manas,
also do infundibulotomy and then take hemostasis if there is a calcium diverticulum during RIRS.
even
Uh,
I don't know, Vamsi, we use this for any specific bleeder of the PCNL tract also we can think of, to be honest. I don't know whether you
yeah,
have tried or not. But
yeah.
their only problem is you don't have a backup tissue, retraction of the, I don't know how the renal parenchyma will behave. If a severe bleeder is there, if you put a
Yeah,
high
we might try, sir. We
it can
might use it for hemostasis.
hemostasis, because this property is tissue gets crumpled and black and charred and then closes the vessel.
Correct, sir.
Manas,
Yes, sir.
I wanted to ask you this question. When you are doing the anterior part, the in block enucleation, when you do anterior part and go directly to the very important question, please listen carefully. When we go anteriorly directly up to the bladder, should we tunnel it or should we do U type from the 9 o'clock to 3 o'clock, what Vamsi says, so that make a broad plane and then enter the bladder? See, in hydrocele, if you enter in one place, after that dissection is very difficult. By chance, if your blade cuts hydrocele, water will come out. After that, dissection of the plane is hella job. Otherwise, if you cut with low current continuously one by plane, and then press with hand, entire hydrocele sac will be seen nicely, and with gauge piece you will do that. Similarly, I hope you are understanding my question.
Yes, sir. Yes, sir.
What is your
Sir,
tip in
sir, what you're saying is mainly doing the en bloc enucleation.
yeah,
Well, doing en bloc enucleation, mainly thing is main fund of doing en bloc enucleation is we need the covered space. That's only between gland and the capsule. There is limited space, good vision, good irrigation, less amount of fluids has been used. So that when we doing the anterior dissection, mainly from the 10 to 2 o'clock position, so full like what you say, horseshoe, semicircle, you have to completely dissect. When we do that one, so that vision will be good, limited, good irrigation from the fluid. Once if you open the bladder at only one level, then the bladder irrigation will go into the bladder and the vision will be less. And again, dissection will be a bit difficult, but not that we can't do, we can do.
not
But
entering over enthusiastic bladder entry should be avoided.
should be avoided. So better thing is should avoid. Just reach, go up to the, you see that bluish hue. Don't perforate that mucosa.
Okay.
Before perforating, continue dissection on either side, so that once you go into the bladder, it will be easy to complete the dissection.
Okay, fine. Now, Vamsi, enucleation long been last 5 years has been questioned by stress incontinence. This stress incontinence, some disturbance is coming.
No, it's clear, sir, for me.
Yeah. So, if enucleation stress incontinence to avoid, there is a big subject. Books are written. What cases? Obviously, incontinence happens. Is it only the sphincter or rest of the surgery is also important? What do you think? Crisp summary. How you can avoid incontinence in large gland enucleation? It should not be inevitable complication so that patient attendants or patients will complain. This is the only concern. I am now convinced that in last 23 cases or 22 cases which I have done after my starting, slowly I am leaving a rim of the mucosa, and then purposefully I am not going in the groove of the gland behind the veru. I am leaving 5 millimeters and then making a deep cut. After that I am enucleating. Gland is coming out, like in mucosa is not going out away.
Correct, correct, sir.
Like that, any points in your, because you have vast experience, more than 10-15 years you are doing enucleation.
Yes.
what is your crisp points on avoiding stressing contents in enucleation?
The same thing, sir. What you told. Your mucosal incision can be anywhere, but mucosal incision you have to leave the mucosa, and it's difficult. You have to maneuver it and then take a bit of gland, and beyond the veru, you have to at least on one side. When I am using a three-lobe technique or two-lobe technique, one left lobe I remove fully. It will be like way beyond veru. You'll see there is a cavity. Right lobe I cut flush at the level of Veru, try to reach the capsule, and there will be a significant gland beyond Veru on the right side. And then I reach the capsule and enucleate. So this gland, not only apex I save, on one side at the base also I save. So these two factors will prevent a stress incontinence. So if you
Oh,
save only at apex, like if you do unblock enucleation, you need both lobes to be enucleated off even at the apex.
that puts more
So
pressure, I think.
yeah, so even if people say that capsule, the sphincter is more in the horseshoe shape, it is only in the roof. Here also, your some sphincter you are going to separate some intervening fibers.
Yeah, yeah,
So I would suggest one side you don't go to the see the apex of the prostate in one lobe. So that
yeah.
has helped me.
And second thing, the people say that cut deep, not only the mucosa, few millimeters deep up to the gland, then enucleate. Enucleation plane anyway will come, but the traction initially will not fall on the.
Yeah, it will be difficult, but it is easier to enucleate fully rather than cutting through the gland and reaching the capsule. It is
That is
actually difficult.
that is difficult. Had it been happens, it is very good because like in TURP you can leave some rim of the
Yeah,
prostatic tissue.
that's the
Uh,
advantage of TURP in stress incontinence. You will anyway coming from superficial to deep, so always have some rim of tissue.
yes, yes, yes. Like last two questions we will take. Manas, you summarize your settings for 60 watts thulium fiber laser for proper enucleation. What is your setting? One point you said.
Yes, sir. Uh, so previously, what we started initially was 1.5 and 33 hertz. But as we increase the gain experience at the apex, initially at the apex near the apical dissection, go to 1 joules 30 hertz, and then as you enucleated the apical tissue, regulated the apical tissue, then you can go up to 1 joule 60 hertz also, 1.5 35 hertz also, sir. For hemostasis, initially 0.1 joules and 300 hertz can be used. If you want more power, 1 joules 30 hertz long pulse also can be used.
One hertz and 30. This is very important.
Long pulse, long pulse.
Can you repeat the settings again for both incision as well as violation?
Initially at the apical tissue, 1 joules 30 hertz. As we go nearer to the bladder neck, when the sphincter has been released, you can go jump up our power to 1 joules 40 hertz also, 1 joules 60 hertz also. Even you can use 1.5, even you can use 2 joules and then 30 hertz also. In the newer machine, we are getting 2 joules 30 hertz also. Whereas coming to the hemostasis, usually 0.1 joules and 300 hertz, it will be enough. But if you want more power, 1 joules 30 hertz and long pulse can also be used.
Okay. Vamsi, you also please summarize your settings for 35 watts enucleation, incision and coagulation.
So incision will be incision and enucleation. Pulse wave mode is preferred. 1.5 joules and 23 hertz is for incision. And I'll check short pulse also, and I'll get back whenever I get the opportunity whether which pulse short. I feel short pulse is better. We will get a better blast effect, I can imagine, rather than a long pulse. And hemostasis, there are usually with the same setting of incision only. Most of the times I achieve hemostasis. If something is not getting a large vessel or something, then I'll choose the hemostatic method, 0.1 joule and 240 or 300 hertz, and I reach the hemostasis. Continuous wave mode, there is only one setting, 30 watt. You can decrease, there is no advantage of decreasing. 30 watt continuous wave mode. If you want to vaporesect or vapoenucleate, like even now, if you want to do there is a poor plane, inflammation is there. I don't want even to do blunt technique. I just want to make a big cavity, or there is a cancer prostate. Then I do vapo enucleation or vaporesection. In that way, 30 watt continuous wave is better, sir.
Continuous. That is the only condition where you recommend continuous wave.
Sir,
Yes.
also point to be stressed is no two laser machines will be same.
That's okay.
Yeah, probably. We are talking
This is
about,
a
I am
broader.
using an IPG machine. So
Yes,
this is
sir.
what I am
Uh,
talking about IPG.
these are broader settings only. You have to
In
use
fact, somebody in our conference, upcoming September conference, somebody who is using Quanta also we should invite. To be
Yeah.
honest, I don't have any experience with Quanta. So if enucleation, or we should bring one time Quanta mission, and then because these two are missions are important missions are IPG now.
Yeah.
We have to look into it. Anyway, today topic is very informative. I think 174 audience have seen the program. Still, many people are online, and nobody has asked questions. But we were discussing fairly good enough. 1 hour has gone simply like that. These are the hot topics and in purely practical. This is what the aim of our pure urology. I thank both the speakers for giving this opportunity. In fact, I am proud that Manas, being relatively junior to me, has acquired a lot of knowledge in enucleation and focusing on the subject. And Vamsi, being in Hyderabadi, I know how much effort you have put in. Now you have started your monthly program also to train. So please, audience, avail. His enucleation as well as RIRS techniques are good. And let's hope these educational programs will continue. Thank you very much, both these speakers.